Hey, Pelvic Posse, and welcome to the Empower Your Pelvis podcast. Hey, everyone. Welcome back to another episode of the Empower Your Pelvis podcast. I'm Amanda.
And I'm Maren.
And today we have Dr. Streicher along with us. She is a gynecologist out of Northwestern out in Chicago who specializes in sexual medicine and menopause. Dr. Streicher, thank you for coming on today. We appreciate it. As I was just telling you, our podcast has not really chatted about menopause or a lot in the sexual health realm yet. So I'm excited to break open that barrier here with you today.
You know, one of the things you mentioned is that a lot of the population that you see is postpartum. And one of the things that people really aren't thinking about is that postpartum morphs into perimenopause sooner than you think.
Yes.
I think that's one of the big myths that we're always talking about is people think perimenopause and menopause and they're thinking grandma, and nothing could be further than the truth. You know, the average age to enter menopause in this country is 51, but that's average. So what that means is it is not unusual for a woman who's in even her early 40s and certainly by mid 40s to be going through these perimenopausal hormonal changes. So it's a common.
I love that you say that because we've had a couple patients, I would say probably in the last month. I've probably had two that have walked in around 46, I think of age of 46 and then 48 who have both gone through menopause.
Well, and particularly because women are delaying pregnancy. You know, it used to be that when you think in terms of who's getting pregnant, what kind of postpartum patients you're going to see in your, it used to be 20s. And that is certainly not the case. Yeah. For all the obvious reasons, women are very often delaying pregnancy. So it's not unusual to be mid, late 30s or even early 40s.
Very cool. Interesting. Thank you for sharing. How did you get into this field and how long have you been doing this?
Well, I've been a gynecologist for decades, and I actually started off as your kind of variety, does a little bit of everything, obstetrics and gynecology and surgery. And then I decided that what I really loved was surgery. So I did give up obstetrics about 15 years ago, and my area of interest was minimally invasive surgery. And I'm also a writer. I always have been. I was actually an English major in college, English and dance.
Oh my gosh.
Lord knows how I got to medical school, but that's a whole other story. And so I was always writing also. And so my first book was about hysterectomy because my pre-surgical consultations were so long that I thought, well, I want to just put this all in writing. And then I continued to write. And what I found that women really wanted to know about was sexuality, hormonal changes. So I started really kind of just focusing more on that. And then wrote a book about sexual medicine, SexRx, Hormones, Health, and Your Best Sex.
I have it.
I'm so happy to hear that. And but then as time went on, I started getting more into the menopause world. And the reality is that even very good gynecologists, for the most part, are not experts when it comes to menopause. It's not something that it's taught, certainly not in medical school. And even during residency, very few people get any kind of a comprehensive education. Wow. And I didn't either. This was something that I learned later. I think like a lot of people that have expertise, it's not something that you start out knowing. It's you have an interest and you follow that interest. So I've always been on staff at Northwestern, but I was doing general practice and surgery. And I was brought on by Northwestern 5 years ago and hired as faculty to start really the first of its kind center in the country that we focused very specifically on menopause and everything about menopause, hot flashes and vaginal dryness and everything you can think of. So I started the Menopause Center. And then we also realized that sexual medicine was a huge part of it because we have women who are in their 20s and 30s who are having painful intercourse and problems with libido and difficulty with orgasm. So we started that center. And then I recently started a vulvar center, which is probably one of the busiest of all. And what makes our centers so unique, in addition to the fact that we offer this expertise, is that it's collaborative. I could not do what I do without my pelvic floor physical therapist. We have 3 of them who are within 15 feet of me, and I could use 20 of them. I mean, every one of our patients basically ends up getting pelvic floor physical therapy. And we have our sex therapists and we have our general therapists and we work with dermatologists and we work with bone specialists for the menopause patients. And we're all physically in the same place. And that's kind of unheard of. You know, you can only imagine, I don't know in your world, but when someone refers a patient to you, and if you want to talk to the referring person about that patient, you got to get on the phone and call them.
Mhm.
And in our clinic, our physical therapists walk across the hall and say, I have so-and-so here, and this is what I'm finding. And hey, could you stick your head in and maybe examine her and see if it's changed from your initial exam? And then we can really get together on it. And it's a unique situation, which is
That'd be
worked out very
amazing.
well.
I know it just sounds like eons away for us, but what a fun niche, like to have that all under one roof.
It's really wonderful. It's much better. I mean, not only is it nice for us, obviously, as clinicians, but from the patient's perspective, I mean, they are beyond thrilled that when I say you need pelvic floor physical therapy, and of course they've never heard of it, and not only can I tell them what it is, but I can introduce them to the person who will be doing it and who can do the 30 seconds, hey, this is who I am, and this is, you know, what you're going to be experiencing when you come back. And it just makes all the difference.
And I feel like there's more patients than that will actually go to pelvic floor physical therapy, because not only did you tell them about it, but then they got to meet the pelvic floor physical therapist right then and there. So they already developed a little bit of a relationship of
That's
knocking
right.
down those barriers.
Yeah.
That's
Where
absolutely right. And our biggest problem, quite frankly, is that we don't have enough pelvic floor physical therapists. I could literally use at least 5 more.
man,
So if you want to come here,
I know, I'm like,
I was there. I worked over at 680.
680 is where my office used to be on the first
Yeah.
floor.
So that's where I was with Leslie Lowe.
Well,
until
Leslie Lowe is who's in charge of our physical therapists.
Yeah. So I was with
you
her.
already
until
know
I
Leslie.
moved.
Yeah, we have a wonderful group. They are
Down in
really
Kansas.
all extraordinary. And I know that if
Yeah.
you work with Leslie, that you are also extraordinary.
Yep, it was wonderful, and it was very convenient being down the hall because we were down the hall from like the OBs and the midwives and
Right.
stuff.
Right.
Yeah, here we have to call, and then we usually talk to a nurse, and then they call us back. But
a little bit more
Yeah.
time consuming,
Yeah.
but hopefully we'll figure out how to create something similar to what you have here and make that a little bit more
It
acceptable.
can be done. It can be done.
Yes. So wonderful history on all of that. What do you find within the menopause, I guess, quotes, because I know that branches out to perimenopause and so many other areas. What do you find that women don't really know?
Yeah.
And maybe it's the whole menopause side of it, but what do they not know that you wish they knew more about?
Well, what we find is that unlike puberty, when a girl goes through puberty and her mother sits her down and tells her what to expect, it's the rare mother that sits her daughter down and tells her what to expect about menopause. And part of that is it's still a bit of a taboo topic. And part of it is, quite frankly, our mothers didn't know a whole lot about
Yeah,
it. So to really
yeah.
can't impart that knowledge. And so what that means is that people are blindsided. And because their doctors aren't talking about it, and we know that they're not talking about it, they're really walking into this, which every single woman enters menopause at some point without knowing a whole lot. So when we think in terms of the top myths, well, myth number 1, we already talked about, that it's going to hit sooner than you think. You know, that everyone always thinks it's someone who's older. And in fact, we see women in their 40s, and that's normal. That's not early. That is normal. Now, we do see women who are even younger in their 30s, but those are women that generally enter menopause as a result of maybe cancer treatments or genetics or some other issues. So typically we're looking at the 40s. People don't expect that. Number 2, that is a big surprise, is people expect hot flashes. They do, but they don't expect them to be as severe as they are, and they don't expect them to last as long as they do. If you were to go up and say to a woman, hey, how long do you think those hot flashes are going to last? She'll go, I don't know, maybe a year, 2 years. Well, a very good study was done, which shows exactly how long they last. And overall, we're looking at an average of 7 years, and that's in Caucasian women.
Oh my
In
goodness.
Black women, it's an average of 10 years. And
Oh,
of the population is forever. So this idea that, I'm just going to tough it out for a year or so and then it's going to go away is not a good plan. The second thing about hot flashes is that everyone has this idea that, okay, it's miserable and it's uncomfortable and it's going to get in the way of, my wearing sweaters and being in warm rooms. But what they don't realize is that it's not just about not feeling your best, but it's also about medical issues that come as a result of hot flashes. It's not just about, it's not just about quality of life. It's also about length of life. So specifically, Women that have hot flashes are the women that are increased risk for cardiovascular disease, stroke, bone loss, even some cancers, cognitive function. And so this idea that hot flashes are harmless is simply not true. Every single time someone has a hot flash, they have a surge of cortisol, there's an inflammatory response, and particularly for women that have severe hot flashes that go on for a very long time, it's going to have an impact. So even if you look and say, for example, the Black population, we know that Black women tend to have more severe hot flashes than Caucasian women or Asian women, and they last longer. There's a reason that many Black women, it's not the only reason, but there's a reason that many Black women are at higher risk for developing heart disease at menopause and early on. So, that's the other big myth out there. And then the other thing that a lot of women are kind of blindsided about is the impact of menopause on your territory, not just the vagina, but also the bladder. And that's something that women are not being told. Even women that are aware that they might develop some vaginal dryness or maybe some pain with intercourse are not told that this also is going to impact their bladder, specifically the urgency, that gotta go feeling, current urinary tract infections.
Yeah.
Because and I know that there are estrogen receptors, not just in the vagina and on the vulva, but throughout the genital urinary tract. And so when women start getting problems with urgency and recurrent urinary tract infections, and they're getting antibiotics and they're getting cultures and then they're getting yeast infections, and it's like, oh my God, please, someone just give them a little bit of vaginal estrogen and this is all going to go away. And that's another big mystery out there. And I think, the overall message that I always want to get across to women is number one, we know a lot about this stuff, but not everybody knows a lot about this stuff. If your own doctor doesn't have the answers, it doesn't mean that the answers aren't there. It just means you need to get yourself to an expert. And all of this stuff is solvable. The words that you will never hear me say are, you just have to live with it. No, you don't have to live with painful sex. You don't have to live with urinary urgency. I know I'm preaching to the choir here because we do all day, every day. But also how few women are getting that message from their doctors.
Yes, absolutely. Can you tap into a little bit of that with our postpartum girls?
Yeah.
So how we kind of think about it, like hormones have shifted after you've had baby. What I've heard, is like you kind of go through how your body's reacting in those postpartum months is similar to menopause with the way progesterone is up, estrogen is down, but how, from your expertise, how would you describe that?
It's interesting because when I first wrote my Sex RX book, I did not have a section on postpartum. And my editor, and very often this is how this goes, she says, well, how could you not have a section on postpartum? And I said, well, it's just a short part of someone's life. And she said, no, you have to. And I started to think about it and I thought, she's right, because for a lot of women, that's when this cascade begins, that they might have had totally enjoyable, pain-free sexual activity prior to pregnancy. And then, not only the sleep deprivation and the body changes, but the hormonal shifts basically sabotage things. And even when, their estrogen levels go back again after they finish nursing, suddenly that pain is there and they don't understand why it doesn't go away.
Yeah.
And then when they go to see their doctor, all too often they're told, well, it's in your head because everything looks just fine now, when in fact it's not in their head, it's in their pelvis because their muscles have gone into keep out mode because they had all this pain again, which is, what you are doing every single day. But so many women don't get that help. They don't find their way to someone like you. So they start this journey of painful sex that starts with the postpartum. And then as time goes on, the pelvic floor muscles, of course, only get tighter and only get more painful because with every single attempt that there's pain, it's 10 steps backwards. And then menopause hits. It's like, are you kidding? Now we're back with not only the tight, painful muscles, but now you've once again got vaginal dryness. So that's why it is so important to address these issues at the postpartum. Because otherwise they are starting down that road of lifelong, not only painful sex, but urinary difficulties, bowel. And no one ever wants to talk about the bowels. We got to talk about the bowels. The same women that are having problems with their bladder are the same women that either have chronic constipation or they're losing stool.
Yeah.
And, no one's talking about it.
That is
Unless
the
you
one
ask, and then it's
question.
like, thank God you asked.
Yeah,
Mhm.
that's the one question I think we see, like their referral coming in and it doesn't say anything about bowels. But as soon as we ask it, even like they're like, oh, I'm fine. You're like, okay, how often are you going? And then you ask, are you having any leakage of stool? Or like you go to the bathroom and you go back a few hours later to go pee again and you wipe. Is there any stool there? Then they finally are like, oh, you know what I'm talking about? Yeah, I have fecal leakage. And you're like, whoa,
You know,
that took a
when I'm
couple
talking to
pieces to get there.
doctors, because a lot of times I think even good doctors, they don't know how to ask the question. And so I give a lot of lectures in the medical community. I mean, I talk to a lot of in the consumer and, with patients, but I also am out there academically talking to doctors. And I basically give them a script. And my script is many women in your situation experience, fill in the blank, whether it's, that they lose stool or this or that. Are you having problems like that? Because when you do that, what you're letting this woman know is she's not weird. This is common. Common and normal are not the same thing.
Mhm.
Yeah.
And it's not normal to lose stool when you don't want to, but it
Yeah.
is common. And when you bring it up, and when I bring it up, it's just such a relief.
Yeah.
It is such a relief. I'm doing a podcast. It actually, my podcast is the Menopause Podcast. And I just taped one that will air probably in September, October, but it's about pelvic organ prolapse and cystoceles and rectoceles and how this happens and what you can do. And one of the things I talk about is that women who have a rectocele, which of course is a weakening in the floor of the vagina so that the rectum is bulging through, that the only way a lot of women can have a bowel movement is to splint, to put their fingers in the vagina and press down. And when I mention this to women, they look at me like, are you kidding? And then when I tell them, no, actually, a lot of people do this. And then they'll kind of go, yeah, I do too, because they just think that they're the only one.
Yeah.
That's why it's so important to have these conversations.
Yeah. Yep.
You mentioned topical estrogen or giving patients that. How often do you feel that you guys are moving in that direction, or how beneficial is it? I guess your population that you're seeing, how many people do you feel that you're doing like the hormone replacement?
Close to 100%, I would think.
Okay.
So when we think in terms of hormone therapy, certainly we're looking at systemic therapy, which is really primarily for hot flashes, bone health, cognitive function. And then when we look at local vaginal estrogen therapy, we are looking at women who have the kinds of problems we've just been talking about with not only sexual issues such as pain and vaginal dryness, but also just feeling kind of irritated and burny and the urinary symptoms. And really all of those women are going to benefit from some kind of local hormone therapy. And while primarily our first go-to is always one of the options for local vaginal estrogen, which is sometimes a cream and sometimes it's a ring and sometimes it's a tablet and sometimes it's a suppository. It depends on, which part we're treating and what we're treating. There's, people don't realize we're treating both inside and outside, and it does make a difference. And in some cases, both. We also very often will give, along with a local estrogen, we use a local testosterone, because many women are not aware that in addition to estrogen receptors in the genital urinary tract, but there's also testosterone receptors. And these are also extremely important when it comes to lubrication, elasticity of tissue, good collagen, all of those things that you need in order to have vaginal and vulvar health. And not everybody needs that little extra bit of testosterone, but we find that many women do. This is one of those things that is what we call off-label, which means that the FDA has not given their blessing. It doesn't mean it's illegal. It doesn't mean it's bad. It just means that we have to be a little bit creative in terms of looking at the medical literature to see what's going to help someone, even if there isn't a product that was designed for that purpose. Sometimes we use DHEA in the vagina, which is a building block for both estrogen and testosterone. There's also an oral drug called Aspina, which stimulates estrogen receptors in the genital urinary tract. And then, of course, we have a CO2 laser program, which is also useful, particularly for women who have breast cancer, who quite frankly can safely use estrogen, but sometimes either they don't want to or their doctors have told them not to. So we always like to offer non-hormonal options as well. So, when we see women who are having these vaginal, vulvar, and urinary tract changes, it might not always be estrogen, but it's going to be something that, because when they come to us, a lubricant is not going to do it. By the time they've gotten to us, they have tried a bucket full of lube, and if it worked, they wouldn't be waiting 3 months for an appointment with us, right? But we do talk a lot about lubricants because there's a lot of lubricants that are not good for vaginal and vulvar tissues. I have one of my podcast episodes is, I think it's called something like, is your lubricant poison or something along those lines. I don't remember if that was the exact title, but the idea that a lot of the lubricants out there, a lot of the common lubricants that people buy, like a lot of the KY products, et cetera, have a very, very high osmolality, which basically means that they can not only dry out tissue. I mean, think about this, lubricate the tissue and it dries out the tissue, but can also break down the tissue and cause someone to have a lot of irritation and inflammation. So even something as simple as switching someone to a lubricant, which is vagina healthy and vagina friendly, can sometimes make all the difference.
I didn't know there were so many different types of estrogen products out there. Because as you were saying that, all I could think of is I've got a postpartum gal who is given topical estrogen, but it's in a tube and she has to insert it vaginally and press it up. But she has so much pain inserting that in that now she just puts it at the top. So we could actually ask her doctor possibly for a different type.
Well, the other thing also is she should not be using the applicator because she needs to treat the vestibule. And so, essentially she should squirt the cream out onto her finger and then apply it generously. Some people have this idea that, you should just use a little dot. No, it should go all over the vestibule, the opening to the vagina. It should go on the urethra and go north and help your clitoris a little bit. Give your clitoris a little love.
Yes, that's what we did. We were like, the tissue's really stuck here. We've got to get mobility there.
And if you can't get through the door, it doesn't matter how nice the room is. So just to put estrogen in the vagina is not going to do it. And as far as all the options, so this is why I wrote my book, Slip Sliding Away. This entire book is about genital urinary syndrome of menopause. This entire book, because there is a lot for a woman to know. She does have choices. I'm a firm believer in being a partner in this. So when someone goes to see their doctor, because if not everyone's going to come to our clinic, right? So if they're going to walk into a doctor, I want them to walk in saying, okay, I know about the cream, but I also know about the ring, and I also know about the insert. I also know about DHA, and I also know about Aspina. She may be educating her doctor. And she can ask for what she wants based on having read about it, because I go into detail in terms of the pros and cons of each product and how do you use it and do what we call dual therapy, that the idea that sometimes we treat just the vagina, sometimes we treat just the vestibule, but in most cases you need to treat both, and you don't always treat them the same way. Which brings me to a really important point. It makes me crazy when women say that they have been treated for painful sex or vaginal dryness and no one has examined them. These women need to have an exam because, first of all,
they're not getting examined by their gynecologist.
Or they'll go to their general doctor and they'll say, oh, well, you're 50. Of course, you're dry. Here's a prescription for estrogen, but they might have lichen sclerosis. Or they might have something,
correct.
Or not only to mention, pelvic floor tension. So I always tell women that that's your first red flag, is if someone has written you a prescription, but has not examined you, has not done a very careful evaluation in terms of what's going on with the tissue, what's going on with the muscles, then they can't really treat you.
No.
And that sounds basic, but trust me when I tell you that we see women every day who have been treated without an exam.
Wow.
That blows my mind.
Especially with like medicine or something topical, the fact that they're giving it to them. Because we see people and sometimes who they haven't had an exam either. And their doctor has just gone based off symptoms, which I'm glad they still send them here.
But at least they're seeing you when you're examining them.
Yeah.
Right.
Even worse is when women, especially young women, are sent to a sex therapist because they're being told it's all in your head.
Yeah.
And they haven't been examined. And then even a good sex therapist, you can do therapy till the cows come home, but if it hurts like hell, you can't talk away the pain. And so one of the requirements that we have, I'm the only one busier than our pelvic floor physical therapists or our sex therapists. And one of the requirements we have to have an appointment with one of our sex therapists is you must be examined by one of our doctors one of our clinicians. We have advanced
Great.
nurses, physician assistants who are great, but you need to have an exam because we need to make sure that there isn't a physical component that needs to be addressed as well. And I cannot tell you how often we identify women who are told it's all in your head and you just need therapy, and we find something. And
That's
then they're just
incredible.
so angry,
Yeah.
that they
I think
weren't.
that's what we see a lot of here is they're just being passed from doctor
Yeah.
to doctor to doctor.
Right.
And finally somebody's like, hey, have you seen a pelvic floor PT? You guys got to go
Right.
get that checked out. And we're thankful, but it's usually been quite a few years.
Yeah.
Yeah, I mean, we are never.
We're like the end of the line.
We're always the fifth, sixth, seventh, eighth opinion. And we've had women who literally have been looking for help for 10, 12 years. And then they come to see us, and one of our clinicians will figure out what's going on literally in 10 minutes. And they're just like, you're kidding.
It's shocking.
How
It's
come
just
other
shocking.
doctors did
Have
that?
you guys seen that change though over the last couple of years with social media? Because that is one thing, like we're seeing people recognize it from Instagram or TikTok and coming in from that.
Yeah, but the point is that they're self-referred. Their doctors aren't sending them.
That's true.
Yeah.
Okay.
Yeah.
And actually we're doing a study right now that we have everyone who walks in the door, we have them fill out a questionnaire that says who referred you. And we are asking, was it a doctor? Was it on social media? Did you read one of Dr. Stryker's books or maybe listen to her podcast? And what we're finding is that about 90% of the women that find their way to our clinic, our sexual medicine and menopause clinic, were self-referred
Wow.
by one of those means, that they read my book, listened to my podcast, or saw something on social media. I mean,
Wow.
even like on Instagram, and I was kind of late to the game with the social media thing. So I'm trying to catch up, and anyone out there, please follow me on Instagram. I need more followers.
What's your handle?
It's at Dr. Strike, STREICH.
There you
And
go, guys.
this week I put a simple little video on that I almost didn't put it up because it just seemed so obvious to me. And it was, when do you stop using your vaginal estrogen? And, basically it's when you die. And I thought that this was kind of, a no-brainer. And last time I looked, I had almost 20,000 views and 1 million comments on it. And this is like news to people. And that's why I have to keep reminding myself that the things that we do every day
Mhm.
are not common knowledge. And so we have to do what you're doing. And what I'm trying to do is to get out there and give everybody this information, which is really going to make a difference.
Mhm.
Yeah, that's incredible.
They are definitely more conversation starters after people follow you and then they'll stop you somewhere or they come in the clinic like, you're from Instagram. And you're like, okay, hi. Like they already know you. They know my kids. They know everything.
Well, social media is a strange thing. And in Chicago, I do the news here every week. I'm on TV and I do a lot of radio, and I've done a lot of national, news and new programs as well. Today Show, Good Morning America, and all that. So people do recognize me,
Mhm.
but I am starting to have more people recognize me from social media, which never used to happen before.
Wow.
Which is incredible because it's all, internationally too. So you get to hear from people from all over, which is really fun.
And when I look at my analytics to see who's listening to my podcast and who's, buying my books, because you can tell all of that. I'm
Mhm.
like, oh my God, I'm number one in Australia.
Aw.
Who knew?
Wow.
Yeah, so it's not just US. I think my podcast, last time I looked, it was about 80% US and 20% other places in the world. It's kind
That's
of fun.
amazing.
That's good. Yeah.
It'll be very cool to see in the next, 5 to 10 years what that's like too and what that's done for you.
Yeah. Yeah.
Very cool. Well, on top of that, something that we ask everybody who we interview is what is something you are learning, doing, or teaching at this time? And you can answer all three, or you can answer one of them.
I am going to tell you about my journey right now in the world of cannabis, because it turns out that I've been doing some research, and that at least, and I think the numbers are higher, but I know that we know that at least 25% of women who are experiencing menopause symptoms, whether it's hot flashes, low libido, difficulty with orgasm, sleep, are turning to cannabis. And the reason that they're turning to cannabis is, number one, their own doctors aren't helping them. Number two is they have, unfortunately, a fear of estrogen, which is unfounded. Estrogen decreases breast cancer, doesn't increase it, but that's a whole nother discussion. And so
Love to
That's
hear
a
more
big
of that
discussion.
later. Yeah.
but
Second podcast.
but but they are on their own turning to cannabis. And this is a world that I've been doing some research in, not only to find out what women are doing, in terms of how are they doing it? Are they vaping? Are they doing edibles? Are they applying it to their genitals? What are they doing? What kinds of cannabis? Who's advising them? And then what is their perception in terms of, is it helping? And it's really a fascinating world. The other thing also is that we know that women postmenopause metabolize cannabis differently than women premenopause, because estrogen is actually in the metabolic pathway of cannabis, and therefore it's metabolized far more slowly, and a lot of women are not aware of that. So in my second book, my Hot Flash Hell book, originally I was just going to have a couple of paragraphs on cannabis, and then when I started to write it, and I thought, oh my God, I could do a whole book on this. And so I do have a chapter on cannabis, not only theoretically, there's no good research on it. I'm just putting it right out there. No one has done those studies, but we do know about the science of the cannabinoids. But more important, if a woman does want to dabble, how she cannot get herself into trouble. So I do have a chapter on that. I also did a podcast on cannabis, which has done very, very well, which also tells you something. And so that's something that I'm learning about, because when I wrote my book, my Hot Flash Hell book, which has been out less than a year, just maybe right around about a year. The truth of the matter is I didn't learn anything writing that book. I was writing what I do every single day in the clinic. This is my world. I know this. I've published in it extensively. I didn't have to really do any significant research. This is what I do. The cannabis part, oh my God. I had to do a lot of research. And so that's what I'm learning new. The other chapter that I actually had to research that I couldn't just write is the one about, I called it Herbs, Spices, and Wishful Thinking. And it's about all of the botanicals, all the herbal things out there that people use for hot flashes. And most of them have not had any scientific studies. And of the ones that have had scientific studies, many of them have been proven not to work. There's really only a couple that have been shown to have any effect at all. Yet women are spending like billions of dollars on this stuff. And I really took my time with that chapter and took every single thing, whether it was Dong Quai or Black Cohosh, and I reviewed the medical literature to see, what in fact we do know. And know a lot more than people think, and most of it is not good. So
wow,
stay away from Chinese herbs. Those are really scary. We don't know what's in there, and a lot of it's really dangerous stuff.
When you did the cannabis study, did you find one working better postmenopausal? And I'm just thinking for my mom's sanity, like for sleep and let's say anxiety.
Yeah. So again, when I talk about what works well, keep in mind this is patient perception as opposed to a real study. A real study, as you know, is you find 1,000 women and you give 50% of them a placebo and 50% of them the real stuff, and you don't tell what's what, and you keep them on it for a year, and then you could look at the data. Mine is a survey, which means that I am saying, do you think it helped you? What is your perception? Yeah. And the numbers are pretty striking. In fact, I'm giving some lectures on it coming up in some of the academic conferences. And sleep, we are looking at well over 90% of women say that the cannabis helps them sleep. In general, we tell them to use an indica, and we tell them to use a tincture, because a tincture has a fast onset, and you don't get that, doesn't last too long. So the next day you're not sluggish. The edibles are tricky. You got to be careful with the edibles. So give your mom a copy of my book. And then
I know, I see it behind you. I'm like, okay.
That's Hot Flash Hell has the cannabis chapter. In Slip Sliding Away, I talk about cannabis just briefly in terms of vaginal CBD, which CBD is a vasodilator. And we know that anything that's going to increase blood flow to the vaginal walls, the vaginal and vulvar tissue, is helpful. Again, there is zero data. This is all anecdotal, and I'm a very evidence-based kind of person. So I'm always very careful to say when we don't have the evidence, but we do have the science behind it, which shows that theoretically it should be helpful, and we know it not to be harmful.
Incredible.
And my next book, which I'm working on now, I put it aside because of the podcast, which took a lot more time than I thought. But the next book I'm writing is called Put the O Back in Mojo, a Postmenopause Guide to Orgasm.
I love that.
Because no one's talking about that. And when we look at sexual complaints post-menopause, libido is number one. Difficulty having an orgasm is number two. And I mean, it's easier to fix someone's ability to orgasm than it is to fix their libido, just saying. Libido is so
I feel like we have better luck with
multifactorial.
that part.
Yeah. Yeah.
We have our pelvic floor physical therapists are doing some really, really interesting work with mapping and orgasmic function. And you should really interview one of them because they're doing things that, to my knowledge, no one else is doing. It's pretty cool.
Interesting.
That's awesome.
Wow.
Love to have you reach out to.
Yeah. Who's still there? Who are the physical therapists there right now?
We have Toshi, we have Helene, we have Catherine, we had Shantae moved away. I don't know if you knew Shantae.
She did. Yeah. She did a lot with endometriosis.
Oh, yeah. She had the endometriosis support group. I think she's in Atlanta now, but I'm not 100% sure.
Yeah, I know Toshi. I used to work with her at my first job as well.
Toshi is, well, they're all amazing. I mean, I am so, so lucky. But yeah, and each one of them they're all good. And then they each kind of have their own area of things that they're interested in, their own area of expertise. And again, the collaborative nature is so amazing. I have this one patient who I saw yesterday who's a very, very complicated patient. And, she saw like 1 million pelvic floor physical therapists in New York and LA. And now, of course, she's with our group and cannot, and she sees both Toshi and Helene because they do different things with her.
Wow.
How specialized they are. So she alternates back and forth. And that kind of collaboration is very unique.
Yeah.
Nice.
That's awesome.
Yeah, I'll reach out to Toshi for sure.
Well, thank you for joining us today. Before we leave, can you tell our clients, our followers, where they can follow you at?
Well, they can follow me on Instagram at Dr. Strike. They can follow me on Twitter and Facebook, and that's at Dr. Stryker. My books, of course, are all available on Amazon. It's called Dr. Stryker's Inside Information Series. And the last two are Hot Flash Hell, which is obviously about hot flashes and slip sliding away, which is all about pelvic health, vaginal and bladder health. And it has been my pleasure to spend time with like-minded people who have the same mission as we do here in Chicago.
Thank you. I could listen to you all day, and we will be ordering these books as soon as possible. So I appreciate it. Thank you so much.
Thank you.
Hey, Pelvic Posse. I want to thank you so much for joining into this week's episode of the Empower Your Pelvis podcast. Can I ask you a couple of favors, please? Number one, can you like and subscribe to this podcast so that you can continue to empower your pelvis forever so that you will never miss out? Number two, can you leave us a rating and a review telling them how amazing we are and everything that you have learned about your pelvic health? And then number three, if you haven't seen the video version of this podcast, you can go over to youtube.com/C/empower your pelvis for all your visual learners out there. We have all types of great visuals in there for you to not only listen to, but to also watch. Thank you so much again, and make sure to give your pelvis some love. Until next time, peace out, Pelvic Posse.